All right. Welcome, everybody. Thank you all so much for being here tonight. Thank you to the onliners, the in-person people. I'm also very thankful to Christ the King and the Cathedral for letting me use this awesome space. To my cousin Joseph, who's helping with the video, audio, and visual, and same with my husband. Just a couple quick things. If you need a bathroom, they're right through this door. So tonight's kind of format is gonna be that I'm gonna introduce Dr. Wells. I'm gonna let him speak, and then we can do some questions and answers. Online, if you guys have any questions, you raise a virtual hand, and my husband will be on top of that. I will then share my story, and then I will take any questions after that as well. So, number one, my name is Kathleen Dennison, and I am a 45-year-old heart attack survivor of SCAD, which we will talk about. I have been a nurse for 23 years, and I've never heard of this condition. I've done cardiac ICU, children's ICU, and that is when I was diagnosed with this. I was like, how have I never heard of this? And so I believe that Dr. Wells and I share a little bit of a passion now about spreading awareness about it. As you will see, and Dr. Wells will talk about, it's the #1 leading cause of heart attacks in women under 50. And that's a lot to not have known about that. And so that is what our goals, I believe, are for tonight. So 3 takeaways for tonight, if you don't remember anything else, is just spread awareness on it. From this, it's going to be recorded. I just would like for you to tell anybody you think. For me, it's anybody that it could affect, be aware of, but also any healthcare providers, having it be on the forefront of your mind if a woman or man comes into your ER or comes into your practice and says, these are my symptoms, you don't look like the heart attack patient, you don't fit the bill, but a light should go on. And that's what I am kind of hoping to change by spreading awareness. That the signs, know the signs, which we will talk about, and then it can happen to anyone. If you go online tonight and Google SCAD survivors, it's incredible. These are all mostly women, because it affects 80% women, but it can affect men. But they're all like me, active, healthy for the most part, young. They do not fit your typical heart attack bill. So anyway, going forward, that is what I hope that you gather from this. I would now like to turn over the mic to Dr. Wells, and we're just gonna sit here and be casual. But Dr. Wells, I just actually met him. This is our second time meeting. The first time was when I was sent to him after my diagnosis. And when I tell you, it was unlike any doctor's appointment I've ever been to. I can't even say it enough. He sat with me for well over 30 minutes, eye to eye, face to face. I felt like I was chatting with a friend. He was so knowledgeable, he was supportive, he was telling me, I didn't do anything wrong, and that's when I get to my story, what I'll talk about, but he also told me, you're gonna be okay. It's just, these are things to know going forward. And in reading people's stories, they traveled to Atlanta to see this man, and that just speaks a lot of volumes. So, without further ado, here is Dr. Wells. Bryan Wells.
Thank you so much. Oh, that looks nice.
Oh, I did this for you, yeah.
That's me.
Yeah, that's you.
All
I
right.
did that for you.
And thank you, Kathleen, for putting this together, and everybody for being here. And I think you hit on the high points that this is a under-recognized condition. And anyone could it could happen to anyone. I think that is a good take-home point, especially if you don't have those, what we consider traditional risk factors with blood pressure, cholesterol, diabetes, etc. And to be aware of those signs and symptoms and to pay attention to that and listen to your body. And we'll get into some of the details about spontaneous coronary artery dissection. And I think we have some of our audience probably is familiar with it, and a lot of our SCAD patients are well informed and challenge us and ask lots of questions. That's a good thing. But some of these, we'll get into a little bit of the research, but if you've never heard of it, please either raise your hand, stop me, interrupt. I don't want to get into too much jargon, but I apologize if I make an assumption, but feel free to call me out on that if we need to clarify anything for you. Does that sound fair?
Yes.
And again, some of it, this is an overview that we give a lot of our patients in clinic about what is the background, how do we recognize SCAD, how do we treat it, and then long-term things that can hopefully reduce our risk for heart attack and other cardiovascular events long-term. Okay, so that's kind of an outline for you there. So this is a typical case. So patients we see in clinic all the time, and I think at this point, like Kathleen said, my clinic is more rare vascular conditions, but this is not uncommon, fairly typical presentation for a 42-year-old woman, doesn't have any other medical conditions, starts having chest pain for 2 to 3 days, and she recognizes that that's concerning, goes to the emergency room. The blood work is also abnormal, suggesting there may be a heart attack, and so we do the heart catheterization. People know what the heart catheterization is, where we put an IV, advance a catheter over a wire to the arteries in the heart to look for blockages. So we did that, and there was no other medical history, like we said, and that's pretty typical for this patient population. Is again being aware of those signs and symptoms, but not necessarily the typical demographic that you think of for a heart attack, right? So the angiogram will show you is the next slide. Okay, and this is what we're looking at in the catheterization lab, and the artery. Is it okay if I stand?
Yes,
right
please.
here? Okay.
I should
Just
have
let me know
a
if I'm out of view or something.
pin lighter. Lighter.
These are the arteries on the left side of the heart. The first thing you might notice is the arteries aren't necessarily straight. They're kind of curly Q, like a curly French fry almost. That's pretty, that's a little unusual for a 42-year-old woman to have all these loops and curls and things like that. But as you go down the artery here, there's some narrowing, where I'm pointing to when the slide runs again. So right here you can see where it's nice, big, good blood flow, and then you see just almost this string sign there, and that is a heart attack or a blockage that's caused by a tear in the inner layer of one of the coronary or heart arteries and not due to the cholesterol plaque buildup. Okay? So that was a SCAD, or a spontaneous coronary artery dissection. Okay, and so by definition, it's not due to trauma or procedure or catheter or something like that, right? And we think it might be occurring in up to 1% of individuals. It's probably more. It's probably because historically it's been under-recognized in younger female and maybe dismissed, but with opportunities like this for increasing awareness and education, that we expect that prevalence to go up. It's most common in females around age 40 to 50, okay? 90% approximately are females. We don't know exactly why that is. It may be related to hormones. It's been difficult to tease that out with clinical trials, but something happening around age 40 to 50 where that risk increases. It's also not uncommon for this to happen during or after pregnancy, so peripartum, due to the stressors of your hemodynamics and blood volume and pushing during pregnancy and all those things, or adrenaline. Pregnancy can be associated with SCAD events too. And then there's this issue of recurrence, and that's why we do a lot of education in clinic about some lifestyle modifications to help prevent these things from reoccurring in the future. Next slide. And here's a cartoon explaining what kind of happens. Okay. So the top left is a normal heart artery, and your heart artery has 3 layers. Okay, it's called the coronary artery, intima, media, adventitia. Okay, and a dissection occurs when that middle layer kind of separates and causes a tear. We actually don't exactly know why that happens, but there's kind of 2 theories about why that happens, and inside out and an outside-in hypothesis, okay? So inside out is what we typically think of as this tear, literally that's separating, like you get a cut on your skin, and there's blood going under that flap, what we call a flap, and it causing a clot or hematoma, and then you have these two lumens, a true lumen and false lumen, but that false lumen compresses the true lumen, and that's what causes the blockage, okay? Conversely, there's another theory that this starts by a spontaneous hematoma formation, which is kind of like a bruise under that intimal layer, and that kind of protrudes into the lumen, causes that blockage. You can see that on the histology here, where, for example, here this is all blood clot or hematoma, and this is where the blood vessel is supposed to be open. So you can see where it's causing that compression or stenosis narrowing to contribute to the heart attack. Okay, next slide. Everybody with me? Okay. And this is again different than when we think about plaque buildup or cholesterol, where there's a focal narrowing, and that plaque ruptures and causes a blood clot on it. Here are some of the risk factors or precipitating factors. When we talk to SCAD patients, we learned a lot of this through our registries. So we pay real patients that have done questionnaires, and we've looked at your medical records and figured out what contributes to these heart attacks. Over 50% of the time, we can identify a physical or an emotional stressor, okay? Intense exercise, an argument, a traumatic event, okay? Sometimes recreational drugs, for example, are something that would increase your heart rate or blood pressure. Labor and delivery, we talked about. Sometimes we don't know, but oftentimes we can identify something, and this gets back to some of those lifestyle modifications where we really need to take care of ourselves and minimize those stressors or triggers as much as possible, okay? And what are some of the risk factors? Again, this is lesser known than atherosclerosis or the traditional heart attacks, but these are some of the conditions associated with SCAD. Has anyone heard of fibromuscular dysplasia? A lot of our SCAD patients, if someone raised their hand, but it's called FMD for short, but fibromuscular dysplasia. We've learned that approximately half of patients have this condition that's more systemic, and it contributes to basically fragile arteries all throughout your body, and most commonly affects the carotid or neck arteries or the renal or kidney arteries, and it makes them more susceptible to tears and aneurysms, things like that. So we see that about half the time. But you can see some other risk factors there. Pregnancy, for example. There's connective tissue diseases that affects collagen and all the tissues all over your body, like your skin and your joints and things like that. So like Marfan syndrome you may have heard of, where people are flexible, hypermobile. Again, that could also affect the arteries and make them a little too flexible to where they're susceptible to tears. Hormones, inflammation. So those are things that we consider risk factors. And that illustration on the left is how we conceptualize it, SCAD at this point. So you have SCAD in the middle there, and then all these other kind of contributing or risk factors, right? Like the FMD, family history and genetics, and inflammation. Migraines are associated with FMD and SCAD. So all these things are associated. We don't know the exact relationship yet, but this is what a lot of our research and focus for diagnosis and treatment is what we're working on currently. And this is just so you kind of understand in cartoon form what the SCAD looks like again. So that we call it type 1, type 2, or type 3 SCAD. Type 1 is where you see that flap or tear right in the middle there, right? Type 2 is the intramural hematoma, that blood formation under that intimal layer, which causes that luminal narrowing that's long and narrow string sign type of pattern. And the 3 is a little more challenging to diagnose because it's like a type 2, but it's shorter. It's less than 2 centimeters. And it makes it diagnostically challenging because plaque and vasospasm and other things can look like that too. But we refer to these things as type 1, 2, and 3 and when we describe what occurred. Next slide. Okay, again, there's a lot of jargon in here and a lot of words, so don't fret about that. This is just an overview. So you've heard some of these things, and again, some of our SCAD patients that may be listening or in the audience are wondering some of the things we do in the hospital when you're coming in with a heart attack. So that goal, you can see there in the red, is to restore blood flow. That's what perfusion is, restore blood flow so you can preserve heart function and tissue, which is called myocardium, as early and as quickly as possible, okay? Sorry, go back. 2 of the medicines that we give, beta blockers, is just a blood pressure medication, but it reduces your blood pressure, heart rate and also the workload of the heart, so it relaxes the heart so it's not getting strained during a heart attack and after. And aspirin, you've heard of it, just decreases blood clots on that flap. Some of the things we don't need to do are other things you may have heard of, like clot busters or stenting, which is PCI. We generally don't have to do that because remember, these arteries are fragile, so we try to avoid that if possible. One slide, one click there. Because we know that 95% of these SCAD events, the artery will heal on its own within 30 days if we took another picture or angiogram image. So we oftentimes avoid the stent because it not only isn't needed, number one, number two, it can be dangerous because that vessel's fragile. It could worsen the dissection and propagate and cause complications like that. So, yes, next slide. So, but this is an example of when we do have to do a stent. Again, just in terms of, so you have some kind of background knowledge here. So the first image A is that narrow blood vessel right in the middle. And in patients where they are unstable, unfortunately, like your blood pressure is dropping, unstable, pain won't go away, it's refractory to the medical therapy, we have to think about invasive options. This is what we consider where the angioplasty or stent, where you pass the wire across that blockage and inflate a balloon to open up and dilate the blood vessel, and you're left with a more patent artery here. Again, there are technical challenges to this. In this case, you can see some narrowing in the artery still much beyond where you place the stent or the angioplasty, and we use the example of squeezing a tube of toothpaste. So if you treat the middle, the blood, the intramural hematoma can go out both ends, and that's kind of what happened here. So it is technically challenging. So these are kind of representative images. Okay, next slide. Okay, and here's some other lifestyle modifications that hopefully everyone in the room can identify with. So one important thing we consider after any cardiac event, but a SCAD as well, as cardiac rehab. And that's where you go to a gym and do some structured exercise therapy with exercise physiologists and nurse supervision, so it's safe, and you have EKG monitoring, blood pressure monitoring. But that's a way to improve your confidence, minimize your symptoms, and improve outcomes long term by doing this exercise 2 or 3 days a week in a structured program at a hospital to improve functional status and outcomes long term. And so we talk about target heart rate. So everybody's maximum heart rate is 220 minus your age, and then you can kind of back calculate and say, we want you to exercise in this moderate zone. So avoiding high intensity activities, competitive sports or CrossFit or heavy lifting or something like that where the heart rate might go a little too high, but that's one of those very important lifestyle modifications that we focus on, because again, many of our patients are otherwise young, healthy women who have a lot of meaningful years left and want to be active and productive and exercise, and those are all really important things to emphasize. So again, these are reinforced in clinic. Avoiding certain medications, so the stimulants or recreational drugs, like I said, things like Sudafed can increase your blood pressure and heart rate. We have a list of medications that we try to avoid. Hormones, that there's a little star by that because it's a little controversial as to whether exogenous hormones like birth control or hormone replacement therapy can increase your risk. We do know that it predisposes you to blood clot slightly. Patients that have had events like this are usually on aspirin, so we feel like that kind of counteracts it, and we haven't seen a huge incidence of recurrent events due to exogenous hormones, but it's something we discuss, risks and benefits of medicines like that. Pregnancy and family planning is important because many patients are of childbearing age, and that's an important conversation to have, and pregnancy, like I mentioned, increases your risk. So it's important to have a multidisciplinary team-based discussion with our OBGYN colleagues and the patient depending on their goals, right? And we screen everybody for fibromuscular dysplasia, that other condition I mentioned, and mental health is also an important aspect of this. Having a support system is very important, and community is very important, and talking to professionals when needed, therapy, psychologists, and taking medications is very normal to have a anxiety, depression, stress response to a major life event like this, so we acknowledge that and try to support you through that as well. Next slide. Okay, kind of covered all this in terms of activities. SCAD is common. Some patients have chest pain afterwards, and we really need to work through, is this a recurrent event? Sometimes, more commonly, it is your vessels are spasming. You know how when you go out in the cold and your fingers start to hurt, right? And some people, it's even called Raynaud's, when the arteries are constricting. That same thing can kind of happen in your heart with stimulation like that. So there are medicines we can use to dilate the arteries and reduce those symptoms. That's what this is about. And recurrence, thankfully, due to some of the treatments I mentioned and increased awareness, rehab activities, lifestyle modifications, we've seen that risk for recurrence decrease over the years. So that's been a good. We used to think it was up to 20 or 25%. Now in this newer study, we've seen a recurrence of closer to 10% or less in a 3-year period. So that's very reassuring as well. Cardiac rehab, we talked about. It's safe, it's recommended for everybody. It's really, really important to emphasize getting back to activity, because it's normal for someone to be anxious about activities after a cardiac event and how much can I do and when, and being sensitive to any pain in the chest area. But this, again, improves confidence, functional status, and outcomes long term. And we have these programs at St. Joseph's and Emory Decatur for our patients here in Atlanta. Okay, some more emphasis on some of the precautions, lifestyle modifications we talked about. And if you have any questions about specifics, we get into a lot of detail with patients about heart rate goals and blood pressure goals and which medicines to take and which activities, depending on someone's interests or hobbies or lifestyle, and that's okay. But these are all things we try to cover when we have these conversations in clinic. Okay?
That's the last
Okay.
slides. Do you want to skip through these?
That kind of was, that's the one that I had, but you had that similar thing. I just thought that was a good representation of kind of what happens, in the tear, and then how it, as the blood rushes through, harder, it tears even further, and then causes the blockage. So that was similar though.
I have a question. That vein on the outside of the heart muscle, does that feed blood into the muscle, or is it?
Yes. Good
Okay.
question. So the on the images that we showed, the example images, yes, those were pictures of the coronary arteries, so the arteries that supply blood to the heart. They you have two main arteries, a left and a right, and you can you see them right in the front in that picture here, in the red and the blue. Okay, that's so you have a left and a right coronary artery, and then they branch just like branches of a tree and get smaller and smaller, so they can supply blood to all of those heart muscles and help it function normally. And so yes, so those images were showing when one is blocked, when one of those arteries is blocked, you'll start to get heart damage very quickly, and that's why the goal is to minimize that in the acute setting, minimize the damage to the heart as much as possible. And one of the important points was, again, listening to your body. Any chest pain, chest pressure, classically radiating to the neck, the left arm, sometimes the right arm, is important to take seriously. For women, it's a little more tricky. Women, we now know, a lot of these studies historically were done on men, right, in terms of study volunteers. So we now know that women may have more atypical symptoms. So it may be a shortness of breath rather than the chest tightness, for example. There may be nausea associated with it or some exercise intolerance. So it's important to be aware of all those symptoms and what might be concerning for that particular individual.
So now we'll go ahead and take some questions, online or in person. Yeah.
Yes. Say in the 1920s or 30s or 40s, I mean, this must have been going on, but how did it, what was done then, and how, when did it become, like, wait, what's really going on here? You know, about how long has it been?
Good question. So our knowledge of spontaneous coronary dissection is much more recent, okay? And in modern medical therapy, we've only been doing these types of angiograms and stents and procedures like that for the past 40 or so years. And a lot of these procedures were pioneered in Emory, so we're fortunate to have expert resources and quality care. People are very proficient in heart diagnosis and treatment. So before then, we treated all patients, men and women, and all types of heart attacks with bed rest and medications, and crossed our fingers, right? And so our technology has improved dramatically, exponentially over the last few decades. And you're right, though, over those years, a lot of the focus was more on men and traditional risk factors, and it's only been more recently that we've recognized some of these less common presentations in women. But unfortunately, some of them were missed. To answer your question, they were missed. They were dismissed. They weren't recognized, and that's because of a lack of awareness and understanding for all of us, right? The patients, the providers, right, our medical knowledge in general. So, and that's why we're here, to increase awareness for the community as well as our providers, and that's my job and all of our jobs. Hopefully that answers your question. Yeah.
Kathleen, what did they do, or Dr. Wells, to you to repair yours?
Nothing.
And Kitty, will you repeat the question, because the
Oh,
people online can't hear.
I'm sorry.
Yeah.
Okay, so my mom just asked, what did they do to me? And I'll go over my story in a little bit. To repair it, they did nothing. And Dr. Palmer, who did my catheterization, is here tonight, which is amazing, and he can speak on that, but they weren't able to do anything. So they just left it alone, they saw it, and then I was put on medications.
Why were they not able to do anything?
Because and you can jump in, but where my tear occurred is such a tiny branch off of the heart that they could not put the catheter through it to even visualize it. And so they had to visualize it from the outside. Dr. Palmer, is that correct? Kinda.
Yeah, so this is the angiogram that we did on Kathleen when she came into the emergency room at St. Joseph. And the red circle, in the red circle you can see this, it's a relatively small artery, so we call it the first obtuse marginal artery. And it's a little bit hard to see, but maybe we could just play it again. But the artery is kind of coming along, and then all of a sudden it gets very small. And so there are multiple reasons to not fix it. And I'm an interventional cardiologist, so I take care of heart attacks, for a living, right? And interventional cardiologists love to fix things. What we do, right? And so it actually takes a lot of restraint to not fix things when we see them like this. But SCAD is one of these diseases that we really try to not fix. And Dr. Wells explained a lot of the reasoning earlier. I think there are two major points. Unlike a traditional heart attack, a more common heart attack, which again is plaque buildup and cholesterol and stuff, which is relatively easy to sort of just push out of the way with a stent or a balloon. In SCAD, the problem is that the artery has torn, and he showed how these, different layers of the arteries are affected, and how you get hematoma and, blood within the layers. And oftentimes, if you try to fix SCAD by putting we certainly could have put a wire down this artery, could have put a balloon down, could have put a stent down. But when you do that in SCAD, you often make the problem even worse. So it's sort of, as Dr. Wells said, propagates. So you take a torn artery that is still flowing, and fortunately Kathleen was, she was having a real heart attack, but she was stable. And so we weren't compelled to fix it. But the problem in SCAD is sometimes you try to fix it and you actually make things worse. So we have to sort of say, look, what are the pros and cons here of trying to fix it? And most of the time we treat these with medication. And the other thing Dr. Wells alluded to is if you go back then a month later and do this again, take pictures again, almost always it's healed by itself. So you don't need to fix it. Now, if a person is very unstable and you know they're sort of crashing and you think they're going to die, then you try to fix it.
Thank you.
I hope that makes sense.
If you don't do
And-
anything to it,
and-
is there a chance for it to happen again?
Ye-
More of a chance?
No, because SCAD could happen in another artery in the
Oh,
same person.
Actually,
And fortunately for Kathleen, I mean, unfortunate that it happened to her, but fortunately, this was this was a branch off of one of the major arteries. So when this happens in a major artery, it's a lot more serious, and it can certainly kill people, and it does. So I hope that makes sense.
no,
Thank
yeah.
you, thank you. And most people do not have recurrence. If it is gonna recur worse, than it usually happens within the first few days, or at least the first 2 weeks. But that inner layer of your coronary artery is tissue, just like tissue on your skin or anywhere else in your body, and it's gonna heal. Just like if you cut yourself or have a scar, there's a little scar there for a few days or weeks, and then it goes away, and that same thing is happening in the coronary arteries. Well, so it heals, just like that's the way Mother Nature made us, fortunately, and that artery's back to normal within a few weeks, most of the time.
Meg, did you have a question?
Yeah, why do you feel like the risk goes down at like 52, 53? Because it seems like the age lines up so much with like perimenopause, menopause, and all the hormone drops that we go through. Do you think that is something to do with it?
It has
Hold
to
on
be.
1 second. So the question is, why does the risk factors go down after 50 years old?
That's a really good question, and it's been difficult to tease out that answer specifically because there's so much going on. When we do our scientific studies, it's a hard thing to measure in terms of menarche, menopause, exogenous hormone exposure with oral contraceptives, hormone replacement therapy, and how much and when. So we're sure all those things contribute in some capacity, but it's a really hard thing to measure and study, unfortunately. So we're not sure yet, but there is probably some relationship there. That's why most of our patients are female, and like you said, there's that peak around age 40 to 50, but there's a lot of things that contribute: pregnancy, menopause, surgical menopause, hysterectomies, other stressors and life events and things like that. So it's a very difficult thing to study, but clearly there's some peak there at age 40 to 50 related to what you're asking about.
Yes.
I have a quick question. So, if women that present with this, do they have a higher risk mortality of dying, or is it more a higher severity of illness?
So the
Like-
question is, do these women have higher mortality, or is it just more severity of illness?
So most SCAD patients do quite well,
Okay.
okay, and continue to remain active with work and exercise and life. Again, most are in the prime of their careers and families, and a lot of milestones going on around that time. There is a higher risk during the acute event. So anyone in the hospital with a heart attack is at an increased risk for a complication. But once you get past that, those first few days, there's a normal prognosis, if you will. That, like we said, that heals. There is a small risk for recurrence that's going down exponentially, especially with some of the treatments and precautions that we outlined.
Can I have a follow-up question?
Yes, please.
So with SCAD, how many times is it dismissed and women pass away?
Mhm.
That's what I want to know. Like, you come in, oh, you're just stressed out, go home, and then I go to sleep and I don't wake up.
So she's asking how often is it dismissed and then the women or men pass away. It's okay.
That's a good question. We don't have a number or a figure to give you for that. I can tell you it's gotten a lot better in the past 10 to 20 years, in particular at academic centers or areas where we have a lot of very, very good experienced, proficient cardiologists who are able to recognize and treat that, and having that index of suspicion when someone is presenting and they're a younger female without any cardiac risk factors, and we're diagnosing a heart attack, think think about why that might be. So we're able to make that diagnosis more accurately. Historically, that wasn't the case. And fortunately, most patients do well. So that might have been missed or dismissed, or maybe didn't even go to the hospital, that kind of thing. But we don't have a percentage of how many misdiagnoses there are out there. But a lot of times we'll never know.
Right.
You know.
Katie?
So it's important to, when you do, if and when this does happen, is to be aware, right? And advocate for yourself and seek medical attention if necessary. Good question.
So I know you said women present differently with chest pain symptoms and stuff, but assuming you do go to the ER, I mean, you have EKG changes like a regular MI, right, with
Mhm.
positive troponin. So you would be on the path for a cath, right? And then that's when they get in there and realize it's not a traditional.
Most of the time, yes. So, sorry.
Mine, I did not have, I had like,
Repeat the question.
sorry, so she was asking about, Katie was asking about if they present in the ER, you know, with EKG changes. As you'll hear in my story, I had mild EKG changes. They were like, oh, it's normal. I had just had an EKG a month prior, completely normal. The only thing that was abnormal for me was my troponin. And I mean, they were talking about letting me go home from the ER, and then it showed up and everything exploded.
So troponin should be positive illness, right? I mean, I guess not the initial day one acute, right? I mean.
Troponin?
In one of your scenarios, it was like the case study was presents with 2 to 3 days of chest pain.
Mhm.
So how acutely does it dissect like a, you know, like
That's a good question.
That's a really, that was actually one of my questions too.
Like
Yeah,
a
there's a spectrum
acute
there.
aortic dissection, you know, there's degrees of dissection, right?
Mhm.
So at what point does it spike the troponin and cause EKG changes so that if you present, oh, I have a little chest pain, but it's,
Mhm.
you know, right, you see what I'm saying? Like,
So the question was, what's the timing from the onset of symptoms to the actual heart attack? And it's variable. So it's not uncommon for someone to have some stuttering chest pain for a few days, and maybe there's the start of a tear or partial blockage. It's not causing the heart attack yet, and then it gets worse a few days later. Or maybe in retrospect, someone had a similar episode of 1 or 2 months prior, and that was probably kind of the same thing going on. But when that heart attack starts to occur and you have enough blockage to where it decreases that blood flow, the troponin, for example, the blood test we check should be positive within 4 hours. And that's why we usually monitor people in the hospital for at least 8 to 12 hours to get at least 2 or 3 of those troponin levels. If you're having that heart attack, it should have been positive within that ER observation period with a few EKGs and a few troponins.
And so everybody knows troponin is a lab that is drawn. It's a cardiac marker that it's kind of the most indicative thing of a heart attack. And so like I said, that was really the only positive thing for me. Normal is less than 0.01, and mine was 596. Yes, Lindsay. Sorry.
What's the best way to advocate for yourself when you go to the hospital with these irregular symptoms, like I'm short of breath, or I have shoulder pain, or it's you present differently. You don't have that classic an elephant sitting on your chest.
Mhm.
So if you show up in the ER and you have a weird symptom, what's the best way to advocate for yourself?
What do you want to take this one?
Sure, I'll take it. The question is from Lindsay, how do you advocate for yourself? You know, for me, when I went, I told them my symptoms and they got me right in. They listened, but again, as you'll hear in my story, everything was normal. So it was it would have been easy for them to say, this is fine, you know? But a lot of the stories that I've read online, the women were adamant. And they said, something is wrong. I need you to do some more testing. I read a story of a woman who called 911. The ambulance came, did an EKG, it was normal. She was like, something's wrong. I need you to take me to the hospital. And they were, you know, kind of balking at it, and she forced them to, and thank God she did. And I'll go over this, but listen to your body. It's telling you something. And, you know, as a nurse, as a a woman, I was kind of like, am I overreacting? Am I being silly about this? But, you know, at any point, like, if you feel something and you'll feel it in your body, I would just push for it. Frazier.
Have you ever had to have a patient have a cabbage for SCAD?
The question is, have you ever had to have somebody have a cabbage for SCAD, which is a bypass?
So yes, cabbage is coronary artery bypass grafting, and that's where we surgically, with usually an artery or another artery or vein graft, implant it into the arteries and bypass, go around those blockages to supply blood flow to the heart. That's very rare, fortunately.
Yeah.
Right? And a lot of our procedures now are more endovascular or percutaneous, like some of the images you saw. When someone has more proximal blockage that is creating decreased blood flow to a larger area of myocardium or heart tissue, that's when we consider it. And so the ostium or the proximal part of the left coronary artery or multiple blood vessels, we think about it. Like Dr. Palmer was saying, we usually try to avoid that because the heart is going to heal on its own. So if we can support the patient for those first few days, then ideally that wouldn't be necessary. If someone is hemodynamically unstable or having a large infarct, we have to do that temporarily to salvage the myocardium. But usually what happens, unfortunately, is those arteries still heal a few weeks later, and then your bypasses shut down because you can't have both open. They're competing with one another. So then the bypass closes. That's okay. At least we've saved the person's life, hopefully, and that's a little more of a drastic procedure that's rarely necessary, but we do that very rarely.
Okay. Yes.
Is it ever okay to ignore chest pain? I mean.
What is the question, sir?
Is it ever okay to ignore chest pain? I mean, what I'm hearing is chest pain over 2 to 3 days, and I'm thinking if I get chest pain, I'm dropping everything. How does chest pain happen over 2 or 3 days?
The question is, should you ever ignore, is it ever okay to ignore chest pain?
Address it.
I think cardiac chest pain classically is pain that is around that retrosternal or chest area. It's a tighten, usually described as a tightness, and it could radiate to the jaw or the arm, and most of the time it's worse with exertion. So when you increase your heart rate or activity level, your heart's a muscle and needs more blood supply, right? It needs more oxygen. And when it's not able to get that, that's when you start to feel it with chest pain. But again, not everybody has classic chest pain or angina symptoms. If it's pain that occurs with some type of emotional or physical stressor and it's not going away, that would be something to take seriously too. If it is pain that is new, or the worst you've ever had in your life, what we might call increasing in frequency or severity, those would all be times to get that checked out. And sometimes depending on the seriousness, severity, or the acuity, you have to kind of decide, should that be an ER visit or should I go to urgent care or see my doctor this week? You know, depending on whether if that pain's going away, you have some time to talk to some healthcare providers about it. If it's not going away, then an ER visit is usually appropriate. And a lot of what we do is reassurance and peace of mind too. So if you get that cardiac testing and we don't find the heart attack, that's okay, right? And it's usually the case, and that's a good thing.
Okay. Yes, Julie.
I have a question about what your experience is with, say, internists, family practitioners, what their awareness is of this. Are there, we have to take our boards periodically, are there board questions about SCAD? I imagine ED, emergency room doctors have some knowledge. What do you think is the knowledge level among your first line folks, your family practitioners and internists?
Question is what is the knowledge of first line? So your family practice doctors on this condition, SCAD.
The knowledge is variable depending on experience and background and area where you practice those types of things. And we have a lot of work to do in terms of education awareness, and that's why we're here. So yes, there is a lot of focus now on cardiovascular disease, particularly in non-traditional settings, right? Things that we haven't historically understood or studied, so board questions and lectures and things like that, to your point. But that takes time, right? And we're doing a lot better than we were a few decades ago, but we still have a lot of work to do.
Okay, if everybody's cool, I'm going to go ahead and move on to my story, and then we can take more questions at the end if that's okay. Dr. Wells, that was awesome. Thank you.
Oh, you're welcome. I'll sit here and
Yeah, stay with me.
I just want to be able to see.
All right. Okay, so number one, be patient. I've never done anything like this before, so if I get emotional or jump around, just give me grace. Okay, so as I said, my name is Kathleen Dennison, and I'm a 45-year-old heart attack SCAD survivor, which is really hard to say. It's kind of like being in AA, I feel like, though. It's kind of like my therapy. I have to say it and get it out. Anyway, as I said, the reason I am doing this is multiple reasons. To spread awareness for people that it may happen to, loved ones, whatever, but also healthcare providers, to be aware and have it be kind of on the forefront of your brain. I have been a nurse for 23 years. I've worked at St. Joseph's in the ICU for 10 years, cardiac. I now work at Children's Healthcare of Atlanta in all of their ICUs. I work in the post-anesthesia care unit. I am one of the school nurses here at Christ the King. I teach CPR. I've never heard of this condition, and I did everything wrong when I had the symptoms. It actually made me kind of happy to see that your case was, they had chest pain for 2 to 3 days. That made me feel a little better about myself. So I want you all to be aware of the symptoms and the things that I did not do right, and that you will hopefully you never experience it. But if you do, or if you know somebody, that you'll be proactive and do the right things. So a little bit about me: grew up here, born and raised in Atlanta. I married a wonderful man, John Dennison, who's here. We have 3 amazing children, Lawrence, Moya, and Patrick. And as I told you, my work experience. And so as you can see, I'm busy. I have a lot going on, but it's life. I've never felt too stressed or too overwhelmed by the things in my life. I just did it. And we have fun, and I never would have said I had this heart attack due to stress, is how I felt prior. Anyway, I'm a good patient. I actually go to the doctor when I'm supposed to. I do what I'm supposed to. I get my mammograms, my pap smears, my colonoscopies. I exercise. I try to eat healthy, working on drinking less. Dry January helped. But I'm a good patient, and I'm active. I'm constantly coaching and playing and exercising and doing with my kids. So when all of this happened, I would have never said, I'm having a heart attack. As I told you, a month prior to my event, I had just had my physical. Had an EKG, had labs. Had I gotten cardiac markers, would they have shown anything? I don't know. It's spontaneous, so maybe not. I don't know. But what happened was on November 13th, I was working here at Christ the King. Again, I'm one of the nurses. And as we nurses do, I was eating a chicken sandwich standing up, because we never take time for ourselves to eat lunch and actually enjoy and sit down and take time. And immediately I started feeling what felt like indigestion, central. And I was like, that's funny. I never have indigestion. I've never had any. My only history is psoriatic arthritis, had an appendectomy, knee surgeries, and that's it. So every time I work here, for my lunch break, I go walk around the good old duck pond. And so I went by myself as I was having indigestion. But it was in the middle, it was on the left, And as I'm walking around the duck pond, I start noticing it's going down my left arm. So right there, I have told you the top 2 symptoms of a heart attack, and I had a justification for both. I could not, I was weirded out by it, but I didn't say, you know what, I might be having a heart attack. So I'm walking around the duck pond, stretching my arms. I'm like, this is strange. I actually talked to Lori Payton, who's here in the audience, and I had an Apple Watch on. Nothing indicated anything was wrong. I got back to the clinic, and I had another nurse, Mimi Bryant, who's amazing, come and take my blood pressure. I just thought it was weird because at that time I started having jaw pain on both sides. Again, there's number 3. And again, I have psoriatic arthritis. I'd been having right-sided jaw pain, but I'd never have it on both sides or bilateral. And it was really intense. And she came, took my blood pressure. It was normal, a little high for me, 120/71. My heart rate was 90. So I was just like, this is just strange. So I took 2 Tums, and the pain went away. And I continued to work that day, but I just didn't feel right. So at 3 o'clock, I took my kids, walked home, and I just said, I'm gonna go lay down. I don't feel right. My pain was gone, the arm, my jaw pain, everything was gone. So I went home, laid down, and I just felt tired. I felt off. My husband came home, and I just said, I don't feel great. I made dinner. My stomach was upset, though, so there comes in the nausea. I just didn't eat dinner. I just felt not good, but I was like, well, I'm around sick kids all day. Maybe I'm just got a virus. I don't know. So my family was playing a game. I was like, I'm gonna go lay down in bed and just read. And I remember saying to my kids when they went to bed, I love you more than anything. I was scared, and I didn't do anything. Why I didn't go to the hospital, I have no idea. Sorry. But thank God I went to bed and woke up. So I'm here to tell this story, but in the night, I remember feeling my body kind of tingle, and it went away. I remember feeling a dull ache in my armpit, and I was kind of rubbing it, and then it went away. So every symptom I had was there, but it went away. It didn't stay with me. I was supposed to be working at the hospital the next day, so I woke up at 1 a.m. to call out from the hospital, sick, thank God. And I woke up in the morning, thank God, and I talk about God a lot because I don't know what I would have done without my faith. It would have been hard to not have that to believe in. But I woke up and I said to my husband, I'm just gonna go see somebody. I don't know, I'll go see a doctor. So I called my primary care physician. They couldn't see me. And so I called a good friend, Dr. Steve Eisenberg, who I owe a million thanks to. I called his office. I'm not really a patient of his, but I just said, this is what's going on. Can I come see you today? And he said, hell no, go to the ER. So again, the next thing I did terribly was I drove myself to the ER. So I went to St. Joseph's Hospital, which was amazing. As I told you, I worked there, and it was literally like a hug going in there. They were amazing. They took me back immediately. And as I told you, they did my vital signs. Everything was normal. They did an EKG. There was mild changes, but nothing that would alert them that I was having a heart attack. They did labs. They did a chest x-ray. They did a head CT because I forgot to tell you at this time I had a massive headache. I don't have headaches. I don't have migraines, and I cannot even explain this headache that I had. So everything was normal. I had told my husband and my mom I was going to the ER. They came, and they were literally talking about sending me home. And then all of a sudden, my troponin level came back, as I told you. Normal is 0.01 or less, and mine was 596. I heard them talking about it out in the nurses' station, and I was like, oh my gosh. And they ran in, and they said, are you having chest pain? And I said, no. And they told me what happened, and I lost it because I knew exactly what that meant, that I was or had a heart attack. And my first emotion, sadly, and maybe this was just embarrassment. Like, what did I do wrong? Where have I gone wrong? And in that time, I shouldn't have been thinking that, but I was. And so at that time, Dr. Lucia Alvarez, I think that's how you say her first name, was amazing. She came in and she said, I think this is SCAD. And so that was her first thought. And that, again, is one thing that I want healthcare providers to understand, is have that be in your brain. And she did. And she said, we have two options, to either go do this scan of your heart that takes a long time, and if something's wrong in that scan, then you need to have a cardiac catheterization, or they have a slot open at 1:30 with Dr. Palmer. And Dr. Palmer was amazing. Again, I worked with him, and then for him to take care of me, it was just so reassuring. And so I said, let's do the catheterization. And then, as Dr. Palmer explained, he went in and, again, you can speak on this, but all of my arteries were clear except for this one spot that is where the diagnosis of SCAD came in. So again, there was no intervention done, but they knew that that's what they were dealing with. So I had to stay overnight in the hospital, and they put me on medications that I'm still on today, which I wish I could go off of. But that was really hard, having to stay in the hospital. It was my son's 13th birthday, and that was tough. My husband and my parents brought the kids, and for them to come in and, see me like that, and then not to be able to be there in the morning was really hard. Mumsy, your ginger's not working. She gave me ginger not to cry. Anyway, I'm so thankful to be here. It was just really hard that day, having to say goodbye to them, knowing I wouldn't be there in the morning to celebrate and do our balloons and fun festivities. But I'm just so thankful that I'm here to celebrate many more birthdays, hopefully. Anyway, I got out of the hospital the next day, and I'm still in, I got to see Dr. Wells, which was awesome.
How did that happen?
I'll tell you. Dr. Palmer and Dr. Eisenberg said that there's a specialist, and it's just such a blessing that he's here in Atlanta, because so many people around the world want a specialist, and there's not a ton of them. So, but anyway, I stayed overnight. They let me go, so I was able to be with my family and my son on his actual birthday night. But it was hard because I came home and I just had a heart attack, but I'm back to being a mom, a wife, working, and it was just, I didn't feel like myself, nor do I still feel like myself. And hopefully that will come in time. I need to give myself grace on that. It has only been 2 months, but as moms, as women, as working moms, I never put myself first. And that is what I'm trying to change now. And I hope that all of you, not just moms, but you got to put yourself first. You got to take time for you, because as of now, I'm still getting testing. I don't have a reason this happened other than stress. And one thing that makes me feel really good is doing this and spreading awareness, and hopefully I can save a life or, you know, help somebody down the way. But also I have been, I'm in the research study at the Mayo Clinic in Rochester, Minnesota, which is awesome. They're doing a huge research study on this. So it just makes me feel better and part of my healing that I'm doing something good out of the bad. I feel like I'm forgetting something, and I didn't cry as bad as I thought. But for me, I just want to thank you all for being here, taking time out of your Sunday. For you guys online, thank you for listening. This month, February, is Heart Awareness Month. And so my homework to you is this is being recorded. I would love for you, and even if you don't share the recording, but just share this information with one person. And that's how we can spread awareness about this. I want to thank Dr. Wells for coming, Dr. Palmer, all my family, my friends, my community, everybody that has been here and supported me throughout this, and will continue to support me. So I think that is all I have to say, but if anybody has any questions, I'd be happy to answer them if I could.
One person online.
Yes.
Yes.
Yes, I'm happy to answer your question.
I have a question, like what medicine did they put you on,
So,
after your SCAD?
so immediately they put me on a beta blocker, a baby aspirin. They put me on Plavix, and then they put me on a statin, which is a cholesterol lowering medication. I have now gone off the Plavix and statin. I'm still on the beta blocker and the baby aspirin. I'm getting a cardiac CT scan next week. I just had my CT scan of my chest, neck, abdomen, and pelvis yesterday. So hopefully I can remain off of those, but that is what they put me on. And as Dr. Wells explained to me, I didn't realize I would probably have to be on something for indefinitely. But as he said, that it's the only proven thing that will decrease the risk of reoccurrence. So if that decreases my chances of having this happen again, then I'm willing to do that. Yes.
Did you have high cholesterol or anything at your physical before?
I didn't. I've had higher, but like no normal, but higher cholesterol, like triglycerides one time, a higher, I think it was like a LDL, but nothing like red alert. It was just kind of higher than normal, but nothing else. And I've never had high blood pressure. I've never had my pressure's usually really low. So that was a big change for me. Yes.
Okay, I have two questions. One, I know this wouldn't help your situation, but I don't feel like I've gotten EKGs and physicals, but you do.
I did.
Repeat the
Was
question.
that a reason?
The question is that she didn't feel like she's ever gotten EKGs at physicals.
Do they normally do that?
I think so.
After a certain age.
Oh,
I still do my physicals, I do.
interesting.
I have to say that at my recent, I'm in my 60s, at my recent physical, my insurance did not cover the EKG without pre-existing condition. Luckily for me, I have myocardial, I have
Yeah, that's lovely.
mitral valve prolapse. He said, yes, that's it, okay, we can give you EKG.
Yes.
It's, that may be
Yeah.
why they don't do it.
Okay.
They were saying that they, some people, unless you have a pre-existing condition, don't do EKGs. But that's a great question.
And then I thought, so you're on aspirin. I thought I heard you say most of these women that come in are on aspirin that have these events.
We
Did I
would
misunderstand
start
that?
the aspirin when they
Okay.
arrived at the hospital. We would initiate aspirin
It's
therapy.
not something you see, okay. Never-
When
I think
they-
I misunderstood.
When I was having my event, they put nitroglycerin on me, and they started me on a heparin drip. at the hospital, just to thin that blood and make sure that everything was dilated enough. Yes, Julie?
I saw on your med list that don't take NSAIDs. Why?
So
The, sorry,
ahead.
the question is, on the med list of not to take was NSAIDs, which is like Advil, and she's asking why.
So NSAIDs can contribute to stress of the arteries in general. It can create arterial dysfunction. It can increase your blood pressure. It can make you a little more predisposed to having thrombosis. We try to avoid NSAID type medications if possible and prefer Tylenol over those because of some of those effects. And it's not a hard stop, can never take Advil or ibuprofen type of recommendation, but if possible, if there was a situation where you needed pain medication, starting with Tylenol first and then an NSAID only if needed.
In all cardiac people or specifically
All,
SCAD?
in all cardiac patients.
Yes, Stafford?
Is it genetic?
The question is it genetic?
So is SCAD genetic? So there's probably a genetic predisposition. Okay, it's not the type of condition where if you have the gene, your children has a 50% chance or a 25% chance. It's not one of those types of genetics conditions, but we found some genes more recently in the past few years, a few, not just one, but a few that are associated with some of the conditions I mentioned, like the SCAD and the fibromuscular dysplasia, even migraine headaches, other aneurysms and dissections. So there's definitely a genetic signal there and a predisposition. We don't know what to do with that information yet, and hopefully in our lifetime that'll help us in terms of diagnosis, prognosis, and targeted therapies as well. So with FMD, we know that if you have fibromuscular dysplasia, there's a 10% chance you have a family member with it. We're not sure about SCAD, but kind of a similar
You're not like where the BRCA gene is for cancer.
Correct. Good question.
So with fibromuscular dysplasia, sometimes it's this event that leads people to that diagnosis, or are most people walking around knowing they have fibromuscular dysplasia at this point and then they have a SCAD? Is that, yeah?
The question is about fibromuscular dysplasia and does,
Which comes first?
which comes first,
Exactly.
SCAD or
question.
fibromuscular
So
dysplasia?
in terms of the presenting symptoms, if you have fibromuscular dysplasia that was diagnosed some other way, there's probably only a 3% or so chance that you're going to have SCAD in your lifetime.
Because
Okay.
of whatever medical management for the fibromuscular dysplasia.
And it's just
or
relatively low
Oh.
incidence in general. So we think maybe 1% of the population may have fibromuscular dysplasia, especially the demographic of middle-aged women. Most of those patients don't have SCAD. Some do, more than the general population, like I said, 3 or so percent. But of patients who present with a SCAD, we find FMD at least 50% of the time as the predisposing cause, the underlying condition that contributed to
You're
the
unaware
SCAD.
of it, actually.
Pardon?
Excuse me.
No, go ahead.
What is that?
The
That-
question is asking what FMD is, or fibromuscular dysplasia.
FMD, we touched on just a little bit. It's a condition of the middle layer of your blood vessels. Okay, remember there was intima media eventus. That middle layer, where it's a little that media, the structure is a little unorganized, and it creates the vessel to be fragile, and it creates areas that could be aneurysmal, where it dilates too much, and sometimes areas where it constricts too much, or stenosis. And actually, the way we make the diagnosis clinically is on a picture. It looks like, has a very classic appearance of a string of beads or a string of pearls appearance in that artery. So it has kind of a lumpy, bumpy appearance, and it's usually in the carotid or the renal arteries, but it's systemic. Again, it can affect the coronary arteries too, in this case with SCAD, but that's how we make that diagnosis.
So you don't know if you have
The question is asking, do you know you have this, or is there an event that then causes you to understand that you have this?
So usually so after you've had an event, that prevalence of SCAD is so high in this patient population, again, 50% or more. That's why we do a CAT scan or an MRI of your brain all the way down to your pelvis to look for FMD or incidental aneurysms or dissections. If it's normal, if we don't see any of those abnormalities, then it's very likely that you don't have that diagnosis, or at least we can't see it. But when we do, we make the diagnosis, and if we find any other vascular abnormalities, those may need some surveillance and treatment also in other vascular beds.
Yes.
Is there any association with elevated C-reactive protein and SCAD?
The question is there a incidence of elevated CRP or C-reactive protein and SCAD?
You have a good audience. These are some high-level questions.
I know.
CRP is good. So CRP is a non-specific marker of elevation, right? And it's a sign of inflammation. It's a blood test that can be checked, and it can be caused by inflammation from anything in your body, autoimmune diseases or infections and other things. One of the slides I mentioned was the predisposing condition slide, and if you saw the very last row, or not the last, the second to last, I believe, was inflammation. So the short answer is yes, but indirectly, right? So inflammatory states, like the psoriatic arthritis, for example, thyroid issues, rheumatoid, lupus, conditions like that cause inflammation and would elevate your CRP 10% of the time that we see that in SCAD, or maybe more. So yes, it's the inflammation piece.
Is there ever a world where it's tested at this certain age when you do a physical? Like, is there a test for it?
They're wondering if there is a test for SCAD during for these, this age group. Is there a test that can be done? And I don't know if there's an answer to that.
So the answer is there's not a test that we can do to diagnose or predict SCAD right now. Not with the EKG, not with the troponin, like we said, unless it's happening right at that moment, or not a test like the treadmill or the stress test or the CAT scan or anything like that, right? So if we scanned an individual before they had their SCAD event, their arteries would look normal or patent. Hopefully, some of those markers, like we mentioned, some of those genetic markers or novel risk factors, predictors that we could use for blood tests, things like that, will help us try to predict risk in certain individuals in the future, but not right now. There's no way to really diagnose or predict it ahead of time.
Anybody else have any questions? Yeah.
So do you recommend women in that kind of age group take a baby aspirin, or?
The question is, do you recommend women in that age group take a baby aspirin?
No, we don't. There are some clinical data that have come out within the past few years about taking aspirin for primary prevention or reduce your risk of heart attack for all of us, for all patients, unless you have a known risk factor or known atherosclerosis, like blockage in your heart or some other vascular bed artery. We would not recommend it for what we call primary prevention. It wouldn't help, and it would also increase your risk for bleeding. Good question.
Someone online had a question.
Okay, online, yes. What's your question?
What are the chances, like, with you having FMD, like, I know it's for SCAD, some people have just regular SCAD and then be diagnosed with FMD. What are the chances of, with you being diagnosed with FMD, of you having another SCAD, or like having a regular SCAD without FMD?
So the question is, does having FMD or other vascular bed involvement predict risk? There may be a slightly increased risk if you have a condition like FMD for having recurrence. That's true. And in general, what we've seen both in our registries and clinically, anecdotally, is that the more vascular involvement you have, it's more associated with recurrent vascular events in general. So if you had other arteries involved, like your carotid artery, renal artery, for example, that may predict your risk for recurrence. But fortunately, the risk for recurrence in all of our patients is fairly low. Right.
Anybody else? All right, if that is it, I thank you. Thank you. Thank you all for joining us, and thank you, Dr. Wells, Dr. Palmer, and everybody for being here. Joseph, John, everybody, thank you.
You did great.
Thank you.